Hello everyone, myself Dr. Maddineni, Srinivas, certified dermatologist from Bharat, India. This video is for the topic discussion of topical Tapinarof 1% cream which is available as a brand name Vtama. For dermatology residents, this video is also going to be very important because this can be asked in the paper 4 latest updates in dermatology subject. We are going to see A to Z about this molecule, so just be with me till the end. And if you are not yet subscribed, please do subscribe to this channel. So just brief intro about this molecule. This is a first in class non-steroidal aryl hydrocarbon receptor AHR agonist. How does it act? What is the mechanism? We are going to see that in the MOA, mechanism of action. Okay, and it's used for the psoriasis, especially plaque psoriasis, and also eczema, atopic dermatitis in USA. And it is mainly the steroid sparing nature which is being highlighted a lot by this brand and also by the dermatologists who are treating, right? So what are the objectives you are going to cover in this video is the US approvals, when did the medication got this, and what are the clinical indications for this medication, and we are going to review the mechanism of action, and also we are going to see the dosage, administration, and what counseling we have to give to the patients who are going to be started on this medication. We are going to see the efficacy, what is this remittive effect, and the safety profile of this topical preparation. And right, so just for the introduction sake, Vtama Tapinarof, as I have already told you, this is non-steroidal topical aryl hydrocarbon receptor agonist used in the strength of 1% cream, and it should be applied once daily. So remember, 1% cream, once daily application, right? This once daily application is very crucial. You will understand this in the adverse effects topic, right? And it is approved basically in the year 2022 for adult plaque psoriasis, right? And in December 2024 for atopic dermatitis, especially in the age group more than or equal to 2 years. Okay, and it's designed for use in these diseases in all the disease severities, right? For mild, moderate to severe. And also this can be used in the sensitive sites, that is the folds, the groin, the face. These are the sensitive sites. It can be applied safely in those sensitive sites also, and very low systemic absorption has been observed in the trial. So this is safe to be used in up to 20% of the body surface area involvement in these diseases. So what is that thing which you have to remember? One cream, once daily application, head to toe usability. This is the point which you can remember. So coming to the approvals and indications in the United States. So remember, this is approved for plaque psoriasis in the adults, like I have already told you, and this can be used in all the severities. There is no labeled limit on duration or the treated body surface area according to the US guidelines. In atopic dermatitis, its use age going to be in the children more than or equal to 2 years, right? And the trial shows significant improvement both in the clinical signs and also in the itch over 8 to 12 weeks of usage. And what is the practical point? This can be used as a monotherapy or it can be combined with systemics as an adjuvant agent. It could be systemic medications or it could be even phototherapy. How does it work? What is the mechanism of action? So basically, simply put, it is going to act as an agonist for aryl hydrocarbon receptor. Ultimately, this will lead to the calming the inflammation, reducing the inflammation, and it will restore the barrier function of the skin, and also it will reduce the oxidative stress. This is a simple understanding, but what is exactly happening, because of which all of these are happening, is in a detailed fashion. If you want to understand, once this cream is applied on the skin, what happens is, you should remember that it should be applied as a very thin layer over the skin. So after the application, this is going to go inside the cell. The cell usually are keratinocytes. For the practical purposes, the keratinocytes are the important cells into which this will go, and it will bind with this receptor, aryl hydrocarbon receptor, right? And this will enter the nucleus, and this will bind to this ARNT, aryl hydrocarbon receptor nucleus translocator, and this will further, finally what it will lead to is the gene transcription. It will activate certain genes and it will cause off of certain genes, it will inactivate certain genes. Ultimately, because of this, what will happen is that we are going to see some important changes. What are those? It will lead to reduced T helper 17 cytokines, that is interleukin 17, thereby which is going to cause relief in the psoriasis and atopic dermatitis. It will increase the barrier proteins, that is filaggrin and loricrin, and it will cause a restoration of the barrier function of the skin. And also it will engage with this NRF2 pathway, ultimately leading to increase in the antioxidant defense mechanism. And it may also reduce the Th2 cytokines, which are relevant for atopic dermatitis more than psoriasis. And finally it will heal by all this mechanism put together, that is it is causing less oxidative stress, and it is reducing the cytokines which are inflammatory, and it is improving the barrier function, and also it is calming the skin by this anti-inflammatory properties. Ultimately it will improve the clinical signs and also the itching in both psoriasis patients as well as the eczematous patients. Okay, and remember the point is, it is not a steroid, it is not a phosphodiesterase 4 inhibitor, it is not a JAK inhibitor. This is completely new mechanism. Okay, so here you can see this is reducing the inflammatory cytokines, it is increasing the filaggrin and loricrin, and also it is increasing the antioxidant responses. Additionally, it has also been observed that it will show some antimicrobial activity, and it may beneficially influence the skin microbiome, thereby reducing cytokine production and the local inflammation. This is an additional point. So what is the dosing and administration? This is available as a 1% cream. If you remember, I have already told that. And most important thing is it should be applied as a thin layer once a day. So what is the significance clinically is, if the patient over applies or if they apply on the normal skin, then the chances of development of this adverse effect folliculitis are going to increase. So that's why patient should be advised to apply this as a very thin layer, and only it should be applied on the affected skin but not to the normal skin. It's not a moisturizer. You should not apply it over the skin like you are using a moisturizer, otherwise folliculitis is going to develop. And you should keep it simple. So one cream for most body areas, it is tolerated from head to toe, right? And also sensitive areas also you can apply it without any problems. Do not use it as a oral, ophthalmic or intravaginal routes, and remember to wash the hands after application, because if you by mistake touch the normal skin, there is a possibility of development of folliculitis. So what are the problems with the storage? It can be kept at the room temperature, so it's not a problem, and no routine lab monitoring is required. In the trials it was found that there is no need for any lab monitoring. Coming to the efficacy, by week 12 it was observed that 40% achieved clear or almost clear clinical signs, and there was a very good improvement when compared to the vehicle, right? So definitely it is the molecule which is causing this improvement. Okay, there is also improvement in the itching. So, and you can remember works across mild to severe disease forms and up to 20% body surface area. It was used in the trials. And long term and remittive effect. This remittive effect is something very interesting. You need to know about this. So in this open label study, it was observed that 41% achieved complete clearance at least once during the usage of this medication. And what is the remittive effect is, after achieving clear skin, patients maintain the clear or almost clear of the drug for a period of 4 months. This is something very interesting. So we give this to the patient, they will use it. After they stop it, it was observed that for 4 months there was this disease free period. This is something very interesting. It is called as remittive effect. So we have to plan the follow-ups accordingly. So we can advise the patient to come after 3 months or 3.5 4 months before the lesions again recur after the stoppage of this medication. And there is no tachyphylaxis which was observed, and also it was observed that there was low discontinuation rate, and because of the consistent safety profile of this medication, right? So these are some of the results which are mentioned in their own website, Vtama website. So coming to the efficacy in atopic dermatitis. So various randomized controlled trials were done, and there was definitely improvement when compared to the vehicle. So the molecule is definitely working. itchy is also being reduced, and it is well tolerated and low discontinuation, just like in the patients of psoriasis. Coming to the benefits, like we have already told, this is non-steroidal. So, the adverse effects of steroids are not going to be observed in this medication Tapinarof 1% cream, and it can be applied once in a day. It can be applied head to toe, right? Low systemic absorption, so no need for any lab monitoring. It is effective for psoriasis, atopic dermatitis. We have seen all this. No labeled warnings are seen, right? And no contraindications as such, except for the hypersensitivity. If the patient is having, then they should avoid this. And there is also no such drug to drug interactions. So, what are the disadvantages? So, remember, the comparative studies are yet to be done. So, because this molecule has been recently FDA approved, right? Adverse events. So, this is something very important. Usually they are mild, but they can occur. Most notable one is a folliculitis and the contact dermatitis. This is going to present as a perifollicular erythema around the hair follicles, and also there will be some form of pus collection. So, this is the picture of folliculitis, and like I have told you, how can we avoid this? By simply not applying it over the normal skin, and by not using this as a very thick layer. It should be applied only as a thin layer, right? So, assess as a newer branded agent, prior authorization may be needed. So, this is something in the United States. So, prior authorization is a must before we can procure this from the pharmacy, and also it is very costly. It is very costly medication, definitely. So, you have to think twice before the initiation, and discuss with the treating dermatologist very clearly before beginning the application of this Tapinarof. So, side effects and risks. So, in the patients of psoriasis, in the trials, it was observed, like I have told you, in 100 patients, 20 patients were developing this folliculitis. So, what can we do once this happens? So, we can advise the patient to pause the medication application briefly, check the technique of application, whether it is applied thin or whether it is applied like a moisturizer, a thick coating. If they are applying, we should advise them to apply it only as a thin layer and avoid the contact with the normal skin. And the other side effects are nasopharyngitis, contact dermatitis. It can also produce headache, pruritus, and influenza, cold like symptoms. Uncommon ones are uncommon. So, and in the patients of atopic dermatitis also, it was observed to produce folliculitis, headache, nasopharyngitis, right? So, local tolerability is there. It can be applied on the sensitive areas of the skin, no problem with that. So, these are the common side effects and the less common side effects of this Tapinarof. Coming to the contraindications, if hypersensitivity is there, then only it is a contraindication. Okay, and special situations, so avoid in the pregnancy and lactation, because we don't have enough studies with this medication. Right, elderly, no meaningful safety or efficacy differences seen in the psoriasis trial. So, we should be very careful while using this medication in these patients. And in the hepatic and renal impairment, LFT, KFT, if they are abnormal, no dose adjustment is required. So, practical points related to this medication is it's a once daily medication, the thin layer, and the patient should wash the hands after application, and it should be used only on the affected skin. It's not a moisturizer. Again and again we have to reinforce this to the patients. Avoid normal skin and minimize, this will minimize the irritation and also the possibility of development of folliculitis. Right, it is well tolerated. So, these are points which are again repeating. So, these are almost all the points which we have already discussed, but in the case of atopic dermatitis, it is recommended in the adult atopic dermatitis guidelines along with the roflumilast. This is another molecule. If you want the information related to roflumilast, in the comment section write ROF for roflumilast video, right? Okay, so we have seen all this. So, this is just like summary, brief summary, key takeaways. We have already seen this in this entire video, right? So, if you are having any doubts, you can put your doubts in the comment section. If this video was helpful, please hit that like button, and if you have any doubts, put those doubts in the comment section. And do subscribe to my YouTube channel for all the dermatology updates and the drugs and the diseases, anything new related to dermatology. Thank you so much. Happy learning. All the very best for your examinations. We'll meet you in the next video. Thank you so much.